Thank you for joining us for today's webinar. Today we're looking at disease-modifying medications in multiple sclerosis. I'm Andrea Salmon, one of the Education Program Coordinators, and I'm joined today by Jane Bridgman, one of our MS Connect nurses. We start all our programs by acknowledging and paying respect to the traditional custodians, past, present and emerging, on whose lands we meet today, no matter where we're dialing in from. I'm currently on the lands of the Wurundjeri people of the Kulin Nation. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. Jane Bridgman is our presenter today, and Jane is a registered nurse with over 6 years experience in disability and aged care. She's also worked with progressive neurological conditions and primary health care. Jane is an internationally certified MS nurse and works at MS as an MS Nurse Advisor. It's our pleasure to have you, Jane, and we thought we'd start today by asking everyone that's currently online a couple of questions just to set the scene, because we know that people are online today for a whole lot of different reasons. So we want to ask you, how long have you been living with MS? So for those people just joining us, this is a poll that you hover your mouse over to answer that question. You might have been living with MS for less than a year, or maybe you're kind of sitting around the 5 years, or maybe it's much longer than that for you. We're interested to know who we've got online today, and for you to be aware also of the other people that are online. So that's 80% of the people have voted. Anybody else like to add their vote to this poll? And then I'll close it off and I'll share that. That's great. That's nearly everyone. Well done. I know sometimes if you're on a phone or a different device, you can't actually do the polls, but I'll share those results with you. So over half the group that are online currently have been living with MS for over 5 years. We've got 20% who are sitting around the 5-year mark, and we've got about 24% online at the moment who have been living with MS for less than a year. So I'm going to assume that means you are wanting different things out of this program. And Jane's put together a whole lot of information that we will cover during this next hour. So another question we thought we'd ask is, tell us about your MS medication. Are you still deciding what medication to start? Or are you perhaps wondering if you're on the right medication? You're on a medication, but you're just not sure if it's the right one for you. Or maybe you're on a medication, all seems to be going well, you're just interested in finding out what's the state of play at the moment. So it's great to get a sense from you all as to why you're here today. So that's great. That's nearly everyone. I'll close that and I'll show you the results. So again, a majority of people who are online today are on a medication, seems to be going well, want a bit more information. 28% are on a medication and they're wondering if it's right for them. So Jane will talk about that towards the end of the program. And 16% of people who are online today are still deciding what to start. So there'll be a bit of discussion about that too. But hopefully we managed to cover something for everybody in the program today. So I'm going to hand over to Jane. She's going to turn on her camera and I'll turn off mine. And thank you, Jane, for joining us.
Thanks, Andrea. It's great to be here, and warm welcome to everyone that's joining us. And I'm extra happy today because of what's happening with COVID and that things are going well. So let's have a look at what we're going to cover. We're going to start with a brief recap of the pathophysiology or the MS disease process. And then we're going to take a deep dive into disease-modifying therapies. We're going to look at the benefits and risks of treatment, when to treat, the process of going on treatment. I'm going to give an overview of all of the drugs that we have available. We'll have a discussion about side effects and how to manage them, and also about decision-making as well. So let's have a look at what happens in MS. In this picture, we can see the brain, which is the yellow background that you can see there. nerve, which is the long thing. There's a few of them in a row. There's the dendrites, which are at the start. They're the spiky little bits. And that travels down to the axon, which is the long thin part. And then messages finally leave that nerve via the axon terminal. And that's how they jump from one nerve to the other. Messages travel faster and more smoothly when the nerve has myelin on it. Myelin is the green little part, and the myelin is supported by a cell called an oligodendrocyte, which looks like the monkey just hanging there. The myelin is the fatty substance that surrounds the nerve cell axon, and it insulates the nerve. The messages that travel down are called action potentials. Down at the bottom of that picture, you can see what I've drawn as the blood system. And in the blood, many cells are found, germs and other things. But I've put there the B and T cells. They're mainly supposed to be outside of the central nervous system. And the central nervous system is made up of the brain, the spinal cord, and the optic nerves. To keep the central nervous system safe from certain things, we have a barrier, which you can see there like those little blocks. That's called the blood-brain barrier. And let's have a look at understanding what happens in MS to cause this damage. A breakdown in the blood-brain barrier is thought to be an early phase in the development of MS. If that blood-brain barrier is damaged or weakened in some way, those immune cells can cross into the central nervous system. So we have T and B cells entering in, and they can go anywhere in the brain, the spine, or the optic nerve. They come in and attack the myelin, and they start releasing antibodies, which causes inflammation to the myelin. Then they call in another white blood cell, their friend a macrophage. And the macrophage's job is to engulf and digest cellular debris or foreign substances. It's part of the cleanup crew of an immune attack. This leads to demyelination, where the insulation of that nerve is kind of stripped away and the nerve doesn't work as well. Sometimes the demyelination can even cause the nerve cell to die, and that's called neurodegeneration. There is a process of remyelination sometimes in which the body tries to repair that damage, but it's not always perfectly repaired and sometimes not at all. The brain is an amazing organ though, and there is some capacity for the brain to reorganize and reroute those messages, which is called neuroplasticity. Neurons also naturally die off with age, and this loss of neurons might affect our neurological reserve. Neurological reserve is very important in MS, and it protects against the negative impacts of the disease. For someone that has had MS for many years, they may not have noticed any impacts from a particular lesion early on near the start of their MS. However, as their neurological reserve declines over years, they may then start to notice those lesions having an impact. This is why it's so important to act timely and prevent as much as possible. Let's have a look at disease-modifying therapy a bit more in depth. Disease-modifying therapies, or that term is often shortened to DMT or DMTs. They are a group of treatments for people with MS. They can be oral, injectable, or delivered via intravenous infusion. We use them in a preventative way, usually over the long term. They somehow interrupt that process that we just looked at that causes new damage. There's a range of medications approved for use in Australia, and they all work by either modifying the immune system or suppressing the immune system. Some of them are maintenance therapies, which means you need to keep taking them for them to work, and other are immune reconstitution therapies. These kind of deplete components of the immune cell and then allow a slow renewal, and we hope that when those immune cells grow back that they are better well behaved and don't go in and cause that damage. The main benefits of taking these drugs are fewer and less severe relapses, fewer, smaller or no new lesions, and also reducing the buildup of disability, which can occur sometimes over a lifetime of having MS. So just making sure that we have the clarity on the differences in MS treatment, we can see here that disease-modifying therapy is proven to slow disease progression, but it has no effect on symptoms in terms of making you feel better day to day. So I liken disease-modifying therapy to sunscreen. It's what you wear all the time or use all the time to keep you safe, but it doesn't help if you're already sunburnt. So if you already have MS symptoms, we then use what we call symptom management. And symptom management can be medication, management strategies, or like physical therapy or equipment that we use to lessen the impact of MS on your daily life. And that's like the aloe vera, if that makes sense. There's also brain healthy lifestyle recommendations, which also can help with slowing the disease progression. Symptom management is its own topic, and we have lots of information on that. And today we'll be just covering the disease-modifying therapies. So, what are the benefits and risks of going on treatment? Well, DMTs work with different parts of the immune system, and that is how we reduce the inflammation that's caused by MS. This helps to reduce the number and severity of relapses. And the inflammation in MS doesn't always result in a relapse or visible symptoms. The silent activity may mean that although you feel well, there may still be changes caused by your MS that we may not be able to see or even pick up with a brain scan. MRI scans have shown that taking a disease-modifying therapy can lead to fewer, smaller, or no new areas of damage in the brain and spinal cord. Treating these visibly active relapses, as well as the silently active parts of MS, is a new goal that is emerging in MS treatment. This goal is often called no evidence of disease activity, or we shorten that to NEDA, N-E-D-A. The aim is to reach a point where you are free of the visible progression of MS and also the invisible disease activity. So it's much like an iceberg. In terms of the risks, all medications do have the potential to cause side effects. With disease-modifying therapies, some people find they don't have any side effects at all. Some people may experience a few just as their body is getting used to taking the drug and then it subsides. Some people find the side effects do persist over time. And occasionally people might find that the side effects are so bothersome or potentially dangerous that we need them to stop taking that drug and maybe switch to another one. So how well do these drugs work? Clinical trials do provide us data to help us compare the number of relapses in people taking a new drug compared with either an existing drug or what we call a placebo, a dummy drug. The trials may also measure the number of lesions seen on MRI scans and changes in disability. Using data from these trials has been used to group the therapies according to how effective they are. These broad categories are published by the Association of British Neurologists. We can see here there's 3 categories. Category 1.1 is said to reduce relapses by 1/3 or 30%. That includes the injectable medications and also Aubagio, which is an oral medication. The middle category is category 1.2, which reduces relapses by about 1/2 or 50%. And that includes Tecfidera, Gilenya, and Mavenclad. Category 2 is the most effective. These work the best out of all of the treatments that we have, and they reduce relapses by 2/3 or around 70%. And that is the infusions that we have, Tysabri, Ocrevus, and Lemtrada. So let's have a look at brain health and when we want to use treatment. The brain is a remarkably flexible organ. When we learn new skills, such as learning a new language or playing a musical instrument, it can recruit new areas to use in these tasks. In a similar way, if a part of the brain has been damaged, new areas can be recruited to help with the tasks that were previously performed by that damaged area. So new areas of the brain can be recruited to compensate when MS causes damage to brain tissue. The capacity of the brain to adapt is called neurological reserve. And the more neurological reserve a brain has, the healthier it is. However, it is now known that MS can be active even when someone is feeling well. Research has shown that only about 1 in 10 lesions actually leads to a relapse, and that the other less noticeable damage can also be ongoing. So even if someone is not experiencing new or worsened symptoms, the brain may be using up some of its neurological reserve to compensate for the damage that's happening. If all of the neurological reserve is used up, the brain can no longer recruit new areas, and the symptoms of MS are more likely to progress and become visible in your life. So early treatment with the disease-modifying therapy, if appropriate, is linked with the best possible long-term outcome. So time does equal brain. So when is treatment recommended? Well, we can see here on the graph that has been designed by the International Brain Health Initiative that starting treatment at diagnosis, which is represented here in the green, shows that it gives a much better outcome than people that start on treatment after they're diagnosed or a little while later, and there's still benefit in that. People that go on no treatment at all is represented in the orange, and we know from evidence that they are more likely to have a worse outcome in the future. So what's the process of starting medication? Well, we do need to have some idea of what type of MS you have. There's 3 categories: relapsing remitting MS, which can sometimes progress into secondary progressive MS, and there's also primary progressive MS. That helps us decide which treatment we can recommend, and quite often the options will be discussed with you, and the doctor may even give you a few choices to choose from. There's also a number of pre-treatment screenings. You should have had an MRI fairly recently, and if you haven't, then one will be recommended. There'll be a number of blood and perhaps even urine tests that are recommended. That helps us look at your current blood cell count levels, check things like your liver and kidney functions, and also check that you don't have any underlying conditions we might not know about, like hepatitis or HIV. We may also need to check if you're up to date with vaccinations, and if not, they will be recommended before you start, such as the chickenpox or even the flu or the pneumococcal vaccine, as it can be hard to vaccinate with some vaccines after you've started treatment. It's best practice that all women would be up to date with their pap smears, and especially if they're going to go on immunosuppression, and is really good practice that everyone would have had a skin check and continue to do so. Then we start the treatment and we look at the side effects and how effective it is. And there'll be continual monitoring, which can include MRIs, more blood tests, and we would recommend you keep up with those monitoring procedures like pap smears and skin checks. So let's start our deep dive into each of the drugs. Let's go into Tysabri. Tysabri is for relapsing remitting MS and is also approved for use in the pediatric and adolescent population because sadly there are some children and teenagers that do have MS. It is an IV infusion that's given every 4 weeks, and when it started, we start at the full dose and then just continue on. It is one of the most effective drugs that we have, and it works by binding to immune cells in the bloodstream, and that prevents them from crossing that blood-brain barrier. And so if they can't get in, then they can't cause damage. When I'm discussing the side effects today, I'm going to list quite a few, but it won't be exhaustive. So I do recommend that you have a look at the full list of side effects. Some of the common side effects can include urinary tract infections, headache, dizziness, joint pain, and some less common side effects include a severe allergic reaction, maybe some discomfort during the infusion, liver problems, serious infections, or something called progressive multifocal leukoencephalopathy. And I'll go into that a little bit later. Pre-treatment screening includes blood tests to check JCV levels, and I'll explain that as well a little bit later. We'll be looking at blood cell counts and checking on how the liver and kidney are going. Once you've started, there will be further blood tests and usually a 6-monthly JCV test. Treatment with Tysabri may increase the risk of developing progressive multifocal leukoencephalopathy. Because that's so hard to say, we shorten it to PML. PML is an uncommon brain infection that can lead to severe disability or even death. PML is caused by a mutation of a virus called JCV, or the John Cunningham virus. The John Cunningham virus is a common infection that's completely unrelated to MS. It's normally kept under control by the immune system, causing no problems. But if your immune system is weakened in a particular way and your body is less able to fight an infection, which can occur when you're taking Tysabri, the JC virus can become active and then cause inflammation and damage to the brain. A blood test can be done to detect the JC virus and give us an indication of your risk of developing PML. There are also other factors that your neurologist will take into account, and that includes the length of time that someone has been on Tysabri. Your neurologist or MS nurse will discuss the results of these blood tests and how we can interpret those to assess the benefits and the risks of using Tysabri. When you start taking Tysabri, you will be informed of the early signs and symptoms of PML, as these can be similar to an MS relapse. So it is important to report any new or worsening symptoms. If PML is suspected at any point, the treatment will be discontinued immediately. Let's have a look at Ocrevus. Ocrevus is for relapsing remitting and primary progressive MS. It is subsidised for relapsing remitting MS by the government, but sadly it is not on the pharmaceutical benefit scheme for people with primary progressive MS, which means that's prohibitively expensive for a high majority of people. It is an intravenous infusion and it's given as a day infusion every 6 months. When we start the infusion, we do give a half dose on day 1 and then another half dose on day 15. And then it's every 6 months after that. That helps your body get adjusted to the medication and minimize your experience of side effects. You will also be given pre-medication before the infusions, including steroids, which work as an anti-inflammatory and also an antihistamine. And that also helps to reduce side effects. It is one of the most effective drugs that we have in that top category. It's been designed to work quite specifically. It targets a particular marker on the B cell called CD20, and it targets B cells that have that marker and destroys them. And if they're not there, then they can't go on and cause damage. Some of the common side effects include infusion-related reactions, and they can occur when you're having the infusion, but also up to 24 to 48 hours after you have the infusion. You may be more likely to develop certain infections like the flu, sinus infections or bronchitis, the herpes infection, which includes things like cold sores or shingles, and other viral infections. Less commonly, maybe even depression. Before starting, we'll do blood tests to check your cell counts to make sure you don't have things like HIV or hepatitis, and sometimes we might need to vaccinate before we start. Monitoring is not routinely required, but different doctors and different clinics will have different protocols in place for how they want to keep a check on you. Let's have a look at Lemtrada. This is the last of the 3 infusions. It is for relapsing remitting MS, but it's most often used in very active cases because of the side effect profile. It's given as a daily infusion and it's given each day for 5 days in year 1, and then in year 2, it's given every day for 3 days. No more treatment is required after that. It's given in hospital, but there may be pre-medications that you're instructed to take beforehand and maybe following as well. It works by binding to and killing those lymphocytes, and it's thought that when they do grow back after treatment, that they're going to be better behaved and not go in and cause new damage to that myelin. Some of the common side effects include overactive or underactive thyroid, infusion-associated reactions, such as headache, rash, fever, or nausea. You may be more likely to develop infections like respiratory or urinary infections, a rash, or musculoskeletal pain. Less commonly, maybe things like a blood clotting disorder, kidney and other thyroid problems, or increased levels of liver enzymes. Before starting, they'll do a blood test and a urine test. We'll be checking things like your kidney and your thyroid, and also check your immunity against chickenpox to see if we need to vaccinate. It's also important to avoid foods that may be a source for listeria about a month before you start Lemtrada, and you should continue eating cautiously during and after your treatment. Listeria infections have occurred as little as 3 days after Lemtrada and as late as up to 8 months after the last dose. You can look online about what foods are likely to have listeria, and you will be advised by your doctors about this, but generally it includes things like cold meats or deli meats, raw or pre-cooked seafoods like smoked salmon, maybe pre-packaged fruits or vegetables like salads or foods from a buffet, soft cheeses, and things like pate. Because of the serious nature of the potential side effects that can happen with Lemtrada, it is vital that you have monthly blood and urine tests every month for 4 years after your last treatment course to monitor your blood cell counts and to check the function of the thyroid gland and kidneys. Let's move on to the middle category of effectiveness. We're going to start with Gilenya. It is for relapsing remitting MS, and it is also approved for pediatric and adolescent use. It comes in an oral capsule and you take 1 per day, usually in the morning. It binds to the surface of those lymphocytes and it traps them in the lymph glands. So if they can't get out into the blood system, then they're not there to go in and cause new damage. It's stored at room temperature, and the common side effects include headache, back pain, diarrhea. You might be more likely to get some infections, and even a type of skin cancer called basal cell carcinoma. Less commonly can be things like pneumonia or swelling in the back of the eye called macular edema. Cases of PML have been reported in people taking Gilenya. The risk of PML on Gilenya is considered very low, but if you are worried, do have a chat with your team about this. Before starting treatment, we'll check your immunity against chickenpox and check your blood pressure and pulse, and we'll also be checking your cell counts and liver function. You'll be recommended to have a full body skin cancer check, and you'll also be required to have an eye exam called optical coherence tomography, or OCT, and we do that prior to starting Gilenya and 3 to 4 months after starting, just to make sure you haven't developed that macular edema condition. The first dose of Gilenya is taken in hospital or a medical clinic under supervision, as it is known to cause just a temporary change in heart rate, heartbeat, and blood pressure in some people. These symptoms are checked for 6 hours and will be monitored. It's not common that this would happen, but if it does, we want you to be somewhere where they can keep a check on you. After you go home and continue taking this treatment, there's no risk later on. It's just when you're having that first dose. If for some reason you do forget quite a few days or stop taking Gilenya for a couple of weeks, once you start again, you will be required to have that first dose monitoring again. With the monitoring, you will be required to have regular blood tests to measure your cell count, liver function, and we might even check on your blood pressure. We do recommend yearly skin cancer checks, and as I said, there'll be another eye exam about 3 to 4 months after starting. Let's have a look at Tecfidera. Tecfidera is also for relapsing remitting MS, and it comes in an oral capsule. You take one in the morning and then one at night, so it's actually 2 tablets per day. It is recommended that you take it with food, and that helps minimize the side effects. When starting Tecfidera, you start it on a lower dose, and that allows your body to slowly get used to the medication. And we do this to minimize the side effects that can happen when you're starting the drug. That includes tummy upset, cramping, diarrhea, and that low dose may be recommended for a few weeks. And then as your body adjusts, you'll go on to that full dose. Some medications may be recommended to you so that if you do have those side effects at home, then you already have a medication with you to manage those side effects. The way that it works isn't fully understood actually, but we do know that it probably works in 2 ways. The first is reducing the inflammation caused when the immune system attacks the myelin and resulting in less damage, but it may also have a protective factor and protect those nerve cells from the damage caused by chemicals during the immune attack. It is stored at room temperature. Common side effects also include facial flushing and feeling hot. So the face and head and neck can get quite red and can feel quite warm. And there can also be gastrointestinal upset, the feeling sick, nausea, diarrhea. Less commonly, there may be a decrease in white blood cells, a rash, and cases of PML have been reported for people taking Tecfidera. The risk of developing PML on Tecfidera is considered very low, but if you are worried, have a chat with your team about this. Before starting, we'll do urine and blood tests usually to check on how your kidney and liver are going, and then we'll do the same thing afterwards as well. Let's have a look at Mavenclad. Mavenclad is for relapsing remitting MS and comes in an uncoated oral tablet. It is an immune reconstitution therapy, which has the potential to induce a long-term or even permanent drug-free remission, and it does deplete parts of the immune system with the aim of allowing it to slowly regrow. When you take Mavenclad, there are 2 treatment courses, 12 months apart. So in year 1, it's taken for 4 or 5 days in week 1, and then we do the same thing in week 5. And then in year 2, you do all of that again. In years 3 and 4, there is no treatment required. The actual number of tablets you will be recommended to take is based on body weight. People who took part in clinical trials didn't need further treatment with Mavenclad in years 3 or 4. And we're still studying what happens afterwards and whether more treatment is required, but it will at least cover you for a few years. It needs to be stored at room temperature, and it works by gradually reducing the numbers of B and T cells and then slowly allowing them to regrow. Common side effects include the herpes virus infection, which could be shingles or cold sores. You may get a rash or some hair loss, and less commonly there could be a reduction in another type of white blood cell called a neutrophil, which can cause something called neutropenia. Before starting, we'll have tests to make sure you don't have anything we don't know about, like maybe tuberculosis, HIV, or hepatitis, and we'll check your white blood cells beforehand. And it would be a good idea to have a pap smear and be up to date with that as well. When starting, you must have very clear instructions from your doctor about how many tablets to take each day, whether it's 1 or 2, and for how many days you're supposed to take it, for either 4 or 5 days. And that is based on your body weight. After starting Mavenclad, we'll do blood tests at month 2, just to make sure those cells have dropped as we expect them to. And then before your second course of treatment in year 2, we'll test again to make sure they have risen again to an acceptable level so that we're not dropping them before they should be dropped again. Let's have a look at Mayzent. Mayzent is the newest drug that we've had approved, and only a few days ago we were informed that it's going to be added to the PBS from the 1st of November. So we're very excited about that. It is for secondary progressive MS, which is a type of MS that can follow on for relapsing remitting MS. It is a film-coated tablet taken orally, and you take 1 per day, usually in the morning. Before starting Mayzent, a test is done to check a person's genotype. Genotype refers to an individual, their collection of genes that they have, your genetic material. This is needed to check whether you can actually take Mayzent and also what dose should be given. It's mainly metabolized by the CYP2C9 enzyme, and so we do this test so we can understand the most appropriate dose, because that tells us how your body's actually going to break down the drug. 86% of people will be recommended a 2 milligram dose. About 13% of people will be recommended a 1 milligram, and 0.4% of the population will not be recommended Mayzent at all. We'll also do blood tests to check cell counts and liver function. And again, on the chickenpox, whether we need to vaccinate, it would be recommended to have a skin cancer check and maybe an eye exam. And for some people, they may also need to have a heart function test. We do start at a lower dose and slowly increase over 5 days before you move on to that maintenance dose that's taken every day. For some people, they may have to have their first dose in hospital, quite similar to Gilenya. The generic name of Gilenya is fingolimod, and the generic name of Mayzent is saponimod. So they are quite similar in the way that they work, but there are clear differences. In clinical trials, it has shown a 21% reduction in the risk of disability progression. It works by preventing the lymphocytes from leaving the lymph nodes and entering the blood, but it's also able to enter the central nervous system, where it can bind to S1P receptors on the brain cells, which are involved in repairing or slowing down the damage that's caused by MS. It does need to be stored in the fridge. Some of the common side effects can be headache, increased infections, abnormal liver test results, and less commonly, tremor, meningitis, or an increased risk of skin cancers. Monitoring after you've started may include blood tests, an eye examination, again around that 3 to 4 month mark, and annual skin cancer checks. Now let's look at the lower category of efficacy, Aubagio. Aubagio is for relapsing remitting MS. It is an oral tablet taken once per day, and we start at the full dose, and there's no real special instructions on starting it. The way it works isn't actually completely understood. However, we think it prevents some of the immune cells from multiplying so that there's then less of them to go and cause the damage. And we store it at room temperature. The common side effects can include increased levels of liver enzymes, nausea and diarrhea, hair thinning or loss. And in terms of the less common side effects, we may see a decrease in blood platelets or peripheral neuropathy. Before starting, we may check blood cell counts, liver function, and blood pressure. As Aubagio is known to be harmful to a developing pregnancy, it's not commonly prescribed to women of childbearing age. If it is, we may even do a pregnancy test before starting, just to make sure that someone isn't pregnant and maybe they don't know about it. In terms of monitoring, we will probably check your liver function afterwards and then continue to monitor things like your blood cell count. Let's have a look at the injectables now. Copaxone is for relapsing remitting MS, and it's an injection that you give yourself. It's taken 3 times per week, and people usually do it on Monday, Wednesdays, and Fridays. When starting, you do start on a full dose, but you'll need some education on how to give the injection to yourself. And we do use an auto injector, which is like a little device that makes it a little bit easier for you to do. So you're not required to kind of manually use a syringe. An auto injector that you may have seen before is like the EpiPen, if you're familiar with that, where you just kind of hold it against the body and press the button. Auto injectors that we use with MS drugs are kind of similar, so it takes a bit of the hard work out of it. Copaxone is not an immunosuppressant. it is actually a synthetic combination of 4 amino acids. Amino acids are what make up protein, and it resembles the myelin protein that surrounds the nerve fibers. So we think that Copaxone actually works as like a chemical decoy and diverts the immune attack away from the myelin. It must be kept in the fridge, and some of the common side effects can be injection site reactions. So where you inject can be sore or painful or get bumpy and lumpy. There can be something called lipoatrophy, which is like indentations in the skin, kind of like a cellulite, but a little bit different. Maybe headache, depression, or anxiety. And less commonly, blood cell changes, thyroid changes, or dilation of blood vessels. Occasionally, though, some people may experience a reaction called the immediate post-injection reaction. This happens quite shortly after you give the injection, and it can last about 15 to 30 minutes. It will go away without any treatment and doesn't cause any long-term problems. It can be quite frightening if it does happen. It can feel like a shortness of breath, flushing, chest tightness, and palpitations. After about 15 or 30 minutes, it should have gone away, but if not, do contact a doctor immediately and go to the emergency department. Pre-treatment screening or monitoring after you've started isn't usually required, but we will keep a check on that things are going well. And finally, let's have a look at interferons. These are the first generation of medications that we had way back in the 90s. We don't use them as much anymore, but there are certain cases where this is still the most appropriate drug. They are self-injectable medications. Avonex is an intramuscular injection, which means we inject the drug into the muscle and is given once a week. The other drugs are subcutaneous, which means they're given in the fat, which is that little part you can kind of grab. Betaferon is given every second day. Rebif is 3 times a week, and Plegridy is once per fortnight. When starting these drugs, we may start on a lower dose and then gradually increase. And with interferons, it's actually a protein that your body naturally makes, and interferons work to dampen down inflammation. So these drugs are just man-made versions of that. They can reduce and even maybe prevent inflammation that causes damage to the nerves. Betaferon is stored at room temperature, but the other ones need to stay in the fridge. Most commonly, people experience flu-like symptoms, including muscular or joint pain, headache, or feeling weak or tired. And less commonly, there could be liver abnormalities, hair thinning or loss, or allergic reactions. Before starting and then afterwards, we'll be checking your blood cell count and liver function. So just to recap, which type of drug did which type of MS? I've categorized it here for you. So most of the drugs are for relapsing remitting MS. Ocrevus does do both relapsing remitting and primary progressive, but is not PBS listed for primary progressive. And then Mayzent just recently has become available for secondary progressive MS. So we talked a lot about the side effects that can occur with these drugs. How do we
Jane,
manage them? Yes.
perhaps we'll give you a chance to pause.
Sure.
And I'll just remind everyone to please pop in their questions along the way. We never not mind having the question ready to go. And Janet's actually asked a couple of questions, and you might be going to cover this. So if you are, that's okay. You can please let us know. But how are you seeing neuros treating at the moment? Are they starting on a lower, less, I don't know what, I'm rephrasing this, so a less dramatic medication and then building people up, or are they going in for the most hard-hitting medications first? What are you seeing happening?
That's a really good question. And there has been a change kind of over time as to the treatment strategy we use. Previously, kind of back in the day a little bit, we may have started with the lower efficacy treatments and said, we'll start you on this. It's quite comfortable. There's mild side effects. And then if you have relapses or new lesions, then we'll kind of bump up a bit and go on to a more effective drug only if we need it. And the benefit of that is that you're not going on something stronger than you need, but the negative is that you're waiting for irreversible damage to happen before you try and prevent it. I kind of liken it to getting contents insurance after you get robbed. It doesn't help afterwards. More commonly now, we start people on the moderate to highly efficacious drugs right from the start because we know that time is brain and we want to prevent all that damage from happening. Most commonly, you should be treated by an MS specialist neurologist, and that is best practice. And they will have aligned how they prescribe drugs with the newest research that we have. I hope that answers your question.
That's great, thank you. And how are they tracking the long-term effects of some of the drugs that are newer?
That's a really good question. So if the drugs have only recently been made, then we're not going to have that really long-term data. But in clinical trials, there are 4 phases of clinical trials. And so even after a drug comes on the market and you might start taking it, they are continuing to monitor people after that. So for some of these drugs, we will have maybe 5 or 10 years worth of data. But if you were to ask what happens to someone who's taken that drug for 40 years, we may not have the answer to that. We just don't know. But I should say, in some situations, these drugs are very similar to drugs that have been on the market for years and years. So there is a bit more to it than that. And depending on the drug, I probably could give a more specific answer.
Thank you. And a few questions coming in that I actually might hold towards the end because I know you're going to cover that decision making about when you might change medication. So I'll hold on to a couple of others for later. Thanks, Jane.
That's right. Thank you, Andrea. So we were talking about side effects, and each drug does have side effects. So let's have a look at managing them. Next slide, please, Andrea, if that's okay. So you should know what to expect in terms of the side effects and also what you're supposed to do about it. You should know what are the commonly reported side effects and what you can do if you experience them. Don't be afraid to ask questions and seek clear clarification and get further information. The best source of information is your MS nurse, if you have one, or your neurologist. It is handy to ask someone like your GP or your pharmacist, but they probably won't see a lot of these drugs often, and someone like a pharmacist in the community won't see any of the infusions ever, so they may not be as helpful and have as much experience. For some of these drugs, there are also patient support programs as well that can help. And if you are experiencing side effects of your drug, do seek regular reviews. Ask questions like, should the side effects have gone away by now? And if they're still there, is there anything else I can do? Often we have little tips and tricks that we know that work, so you should reach out and ask questions. And that leads us to the idea of changing medication. People do change therapies. It does happen. Mostly if you ask someone who's had MS for 5, 10, 15 years, they'll say, oh yeah, I started on this for a little while, but then that happened. So I changed to this and I was on that for a while. So it does happen. So how do you know when to change? Well, most importantly, if there is any MRI or clinical evidence that disease activity is poorly controlled, this should prompt a discussion about the possibility of changing to another drug that may be more effective or works on the body in a different way. Things like new lesions or relapses may tell us that the drug is not as effective as we need it to be. And having a think about worsening disease, whether there's side effects that we need to consider or lifestyle changes, and also other changes in health, or if there's better options that are available. In every appointment, you should still be asking, is this drug the right one for me? Are there better options? And if you feel like your neurologist isn't engaging with you in that discussion, have a chat about why you think the drug you're on is no longer appropriate, and you definitely can get a second opinion, and an MS specialist neurologist is always best practice. So let's look at decision making. What should you consider when you are in the process of starting your first drug or perhaps changing to another one? MS is not the type of condition where we can clearly say, this is what we expect in your future, or this is the prognosis. But your neurologist can give you some idea of the likely disease course and perhaps how active they think your MS is now. So that can help. You should also have a think about your treatment goals or your desired outcome. Often we think about the vehicle first before we decide on the destination. So think, where do I want to end up? And then how can I get there? And that often tells us where we should start. So have a think about what you're trying to achieve with this treatment, and also ask your neurologist, what do you think we can achieve with these different drugs? We need to consider health conditions. MS is not an exclusive condition. It will let you date other illnesses. So there may be other things we need to consider when picking a drug. You'll also have your personal values and beliefs, and they do matter. So do raise them and make them part of the conversation. We also need to consider your lifestyle. It's all good and well to say, okay, well, you need to inject this drug. Are you someone who is really afraid of needles, or perhaps you work shift work and you're never awake or asleep at standard times? So taking a tablet morning and night every day at the same time just isn't going to work for you. These drugs only work if you actually take them. We also need to consider your access to healthcare. Most of you will be able to access Medicare, but some people I speak to aren't. So we do need to consider that. And also, what's your proximity to a hospital? Most of us are lucky enough to be near a hospital, but if you do live in the regional or remote areas, having something like a monthly infusion is a big deal. I might only have to drive half an hour, but if you've got a 6-hour return trip, that just might not be viable for you. We, of course, need to think about the side effects and how they might impact your life, and the monitoring requirements. Something like Lemtrada, you do have to have that monthly test for years and years and years. Are you going to be able to do that? Do you think you're the right person to commit to that? And also future plans. Perhaps you are planning on having a baby in the next couple of years. And it's a bit different with COVID now, but normally I would say, what are your future plans? If you're planning in the second part of next year to go traveling around the world, then we need to factor that in what we're doing now. When I speak to people often about choosing between treatments, they're often frustrated because there's no good option. And I understand that. They're sometimes a bit tough. So often we start the opposite way and think, well, what is the most worst option? And ideally, you would pick the least worst, if that makes sense. So sometimes there isn't a good option, but go for the least worst option. I've put here a slide on resources, and it's so important that if you are doing research about drugs, which I do recommend, it needs to be reputable. There is so much information available that is not accurate. It also needs to be current. Some of these drugs are very new, and the research that we know about is very new. So if you are reading books that are years old or things that aren't up to date, you're not going to get the best information. And you may also be interested to know that whilst MS is the same in other countries and the drugs are the same, the access is different. So if you're reading someone's perspective from New Zealand or the UK or the United States, they don't have the same access to the drug. So they may have a different experience of what they think the benefit is, or at the stage they're accessing medications. I've put some good websites here. The UK-based MS Trust is a really good website, and you may also be interested in receiving the newsletter from MS Research Australia. They often will review what's new in the community and actually give us their opinion, so they can digest that information for us. There's also an MS clinical trials network. So all of these drugs that are available have gone through clinical trials, and there are clinical trials happening right now for disease-modifying therapies, but also lots of other things. And they do need to recruit people just like you to help us see what works. So if you want to help out in that way, or perhaps maybe get access to a treatment before it's available on the market, that's a good avenue. I've also included a link for the MS longitudinal study. This is a survey-based research study that has been running since 2001, and there's now thousands of people that complete these surveys. It's designed to provide us with real-life data about MS in Australia, and we use that data to provide better things for you. It's also important to modify lifestyle factors. Modifiable lifestyle factors are aspects of your life that can influence how your MS progresses over time. And the modifiable ones are things that you can change. These are things like diet, exercise, gut health, and using supplements, just to name a few. MS Research Australia has been working with clinical and research experts alongside people living with MS to produce an evidence-based practical guide that empowers you to make the best choices to minimize how your MS progresses over time. So click on that link and have a read of that resource. It's not very long and I highly recommend it. And just finally, if you want to have more of a chat, we often have long conversations about drugs and we're very happy to do so. I work full time and I have a colleague, Bridey, who's also an MS nurse advisor, and you can contact us through MS Connect. You can call or email them and say, I'd like to have a chat with the nurse, and then we can talk more one-on-one about your individual situation. So I'll hand back over to you, Andrea.
Thanks, Jane. That's been fabulous. So much depth of information. It's wonderful. I'll go to a couple of questions, if you don't mind, that people have popped in. And as I say, if we don't get to them all or you don't feel like your question has been answered fully, please follow up with us afterwards because there's a lot coming in. A couple of people are asking questions around secondary progressive MS. They're currently on another medication, but you've mentioned Mayzent in the presentation. Would that be something that they should perhaps talk to their neurologist about? Are there some advantages to Mayzent that aren't perhaps in their current medications that they're on?
Absolutely. So we didn't have an option for secondary progressive MS before now. And the other thing about secondary progressive MS is the transition from relapsing remitting to secondary progressive, it doesn't happen quickly. It's not like on Monday it was relapsing remitting and then Tuesday it's secondary progressive, and we can tell you it happened there. It takes time for us to figure out which type of MS you may have and whether that transition has happened. And it's an assessment. It's not like we do a blood test or something. So there is sometimes a blurry line between whether someone is relapsing remitting or secondary progressive. Mayzent won't be appropriate for each person, but for a lot of people, it may be something that the neurologist considers worth trying. And so this is the time that we would expect neurologists to be having those conversations with you to say, a newer drug has just become available. Let's have a chat about whether that's an appropriate move for you.
Thank you, Jane. That's great. A couple of questions coming in around COVID and medications. So for Gail, her prescription of medication was altered, and another person asking similar questions. So and I know it's hard to comment on every medication, but in general, what's the feeling around medications for MS and COVID?
Yeah, really good question. We know that the immune system is our security team. So our immune system is what's going to fight infections. And if we have COVID, then our immune system is what's a part of fighting that fight. So it's very reasonable to be anxious about COVID. Our understanding of MS medications and COVID has changed as COVID has gone on, as the whole world has learned about how it affects people. There are some resources that are really helpful in understanding how your treatment may affect that. It is different for every person, but with these treatments, there is an article on MS Australia's website, which breaks down a little bit about which drug is kind of which level of immunosuppression, if you will, and has a bit more information about that. But the best thing you should do is continue taking your medication as advised, and then have a chat with your neurologist about what they think. For some people, the medication they're on is the biggest predictor or the biggest concern, but for other people, it might not be the drug, it might be that they have asthma, or that they are a smoker, or their age. And these are other risk factors for a poorer outcome of COVID. It may also be the lifestyle that you live or the people that you live around that we have to consider as well. So it's not just as simple as saying, because you're on this drug, we need to do this. But there have been situations where the prescribing habits have changed, or we've told people just to slightly modify what drug they're on just at the moment whilst we're figuring out what happens.
Thank you for that. A question that might be getting too specific, but I'll ask it to you anyway. The comment about monitoring disease progression to assist with making the decision about switching medications. The commitment to Mavenclad is quite a big one. You know, you're making a 4-year commitment to a treatment regime. At what point would they be looking at the MRIs and deciding that that wasn't effective?
I think most people should be having regular reviews with their neurologist, whether that's 6 monthly or yearly. Regardless of what you're doing with treatment, you should be having MRIs and a chat with a neurologist to see how things are going. So that should be happening throughout the course of Mavenclad. And in isolated circumstances, we have seen that people may have needed to have further courses of Mavenclad or switch on to another more effective drug. So there should always be conversations at your routine reviews about, if you're on treatment, how that's going. Even if you're not on treatment, how is your MS going? And continuing to look for signs that we may need to change what we're doing.
Great, thank you. Thank you. That's great. A couple of other comments coming in. Keeping a diary is really helpful regarding symptoms and general well-being so that you can report that back to your neurologist. That's a great one, Jana. Absolutely. And a question, more a comment, I think, really about the value of having those discussions around family planning and women's health, because often that's overlooked and it's not talked about. So that's great.
Absolutely.
I think we've pretty much covered the questions. I'm hoping people are feeling that I've brought some together and covering those. Sorry, there's a lot here, and I'll just finish off with one. If a medication isn't working, would the consideration be for another medication of a similar, or do you step up? So you know how you had your categories of the medications. What would normally be the process?
Usually you would go to a higher level of efficacy, but it does determine on the individual circumstances. Sometimes it may just be appropriate to switch to a drug that works in a slightly different way, but it's in roughly the same category. Most often it would be to a higher level, but that's not always the case. And that's the benefit of seeing an MS specialist neurologist, someone that's a neuroimmunologist. They understand this like you would not believe. And so their input on your specific situation and their knowledge of how these drugs work mean that they can give you expert advice on the best choice.
Great, thank you. There is another more specific question, but I might get you to follow that up afterwards. So thank you, Jane, for your time today, and thanks everyone for being online and contributing so well to the questions and the discussion. It's always great to have the chance to ask questions and to, you know, get more specific advice. So don't forget that if you want advice for your own situation that is much more specific, that's when you want a phone call to Jane or Bridie to have that conversation. So thanks everyone for being online. We look forward to seeing you at future webinars, and thanks again, Jane, for your time today.
Thank you.